very important clinical picture. We have a lot of questions which will be after Professor Elham.
Now it is my turn to introduce Professor Elham Hossny. Professor Elham Hossny is the Secretary General of SPI, and in the meantime, she is the ex-chair of the Pediatric Allergy and Immunology Unit of Ain Shams University. She is the Vice President of the Arab Association, Arab Society, Pan-Arab Society of Allergy and Asthma and Immunology. Professor Elham Hossny with Professor Zainab Awad are co-editors of the World Allergy Organization Journal and are co-editors of the Egyptian Journal of Pediatric Allergy and Immunology. Professor Elham Hossny is actually actively sharing in all activities of the World Allergy Organization and in the activities of the American Academy of Allergy, Asthma, and Immunology. And she is going to speak now about management of hereditary angioedema.
Thank you very much, Professor, for your kind introduction. You've given of credit that I don't really deserve. I'm so much interested in hereditary angioedema. Although it's a rare disease, but in a population of 100 million, you should expect a lot of cases. At least 2,000 or 3 persons in this country are endangered by hereditary angioedema. And unless we can have a good awareness of the disease and a high index of suspicion, they are not going to be diagnosed, and then their life is endangered. I have no disclosures. I'm going to start by the international guidelines of the World Allergy Organization and the European Academy of Allergy and Immunology, which was in 2017. They said that with autosomal dominant inheritance, the offspring of a patient with hereditary angioedema have a 50% of inheriting the disease, and that children from families affected by this disease should be tested as soon as possible after birth in order to avoid morbidity and mortality. Why should we see family members of individuals? Because delayed diagnosis leads to decreased quality of morbidity, and because there is a risk that the first attack could be fatal due to airway involvement, as we have heard from our dear colleague Rasha. Laryngeal edema could be the first presentation, and the patient and the child is going to die without being even diagnosed, without being given the chance to be diagnosed even. Many cases that we lose in casualty or the emergency room could be hereditary angioedema. Many cases have exploration surgery of their abdomen and appendectomy without a reason, could be abdominal due to hereditary angioedema. So whom are we going to screen for? Family members first of individuals with HAE, and patients with recurrent angioedema without any urticaria or should be considered for screening for HAE. All patients with unexplained recurrent abdominal pain, especially those who are afebrile. Not every, as Rasha said, not every attack of abdominal pain should be FMF or familial Mediterranean fever. If it is afebrile attacks, then you should consider the possibility of hereditary angioedema, and you will never know unless you screen for this. What are the main tests for hereditary angioedema? Of course, the prototype concentration of C1 inhibitor, but normal levels of C1 inhibitor doesn't rule out type 2, in which there is there is normal level but low functional activity. But very low C4 level in the serum due to increased cleavage of C4 by C1 happens in every case of hereditary angioedema, and it is the cheapest solution. So, every hospital, every medical center in Egypt can measure serum C4 at a low cost. So this is a screening test. If you find the C4 level low, then the case deserves to be put into C1 inhibitor estimation. As you can see, we have two types, the main two types of hereditary angioedema. Type 1, the concentration of inhibitor is low, the C4 is low. And of course, the functional assay, which is not done easily in many laboratories in Europe, even in the US, not every lab can do the functional assay of C1 inhibitor, not only Egypt, and it's a very expensive test, but it is going to be low even in type 1 because the concentration is low. In type 2, you will find the concentration of C1 inhibitor in the serum normal or increased, but the C4 level is still low and the C1 functional assay is low. So you have the C4 level, as I said, as a good screening tool in this, especially if you measure it during the attack to find it consumed. So what are the main laboratory features of bradykinin-mediated angioedema? I'm not speaking of allergic angioedema at all. It's not in our domain. It's accompanied usually with urticaria and itch. And this is a completely different pathogenesis. It's not our problem. C4 is decreased in hereditary types, whether type 1 or 2. C4 is also decreased in the acquired type, which occurs usually in patients of systemic lupus erythematosus. They come with angioedema without an explanation, without even itch, and then you find that the C4 level is low, is even lower than the hereditary type because there are other causes of lowering of the C4, including complex pathogenesis in cases of systemic lupus. The C4 is going to be normal in the other types I'm going to tackle immediately, such as what we call type 3 hereditary angioedema or factor 12 mutation that was explained by my colleague, Dr. Dalia El-Ghunaimi. Also, the drug in AC angioedema, the angiotensin converting enzyme inhibitors, captopril, which is an antihypertensive, you will find the C4 normal. Even the chronic spontaneous urticaria, which is idiopathic histaminergic angioedema, you will find the C4 here again normal. C1 inhibitor is decreased in type 1, normal or increased in type 2. It is decreased even sometimes in systemic erythematosus or the acquired of C1 inhibitor deficiency, but it's normal in 3 types. C1 inhibitor function, again, is decreased in both types, type 1 and type 2 hereditary edema, normal in the acquired type, or sometimes a little bit decreased, and normal in the 3 other types. C1q, and this is very important because I find many physicians asking for C1q to diagnose hereditary angioedema. It is not a test for hereditary angioedema. It is in about more than 95% of it is normal. And it is a tedious test, expensive, so don't put your patient into an unnecessary investigation, let him pay for this. It is decreased in the acquired type or systemic lupus erythematosus due to the presence of antibodies against the C1q. But it's not a method to diagnose hereditary angioedema. And it's, of course, it's normal in the other types. C3 is normal in hereditary angioedema. Please do not ask for C3. C3 has nothing to do with hereditary angioedema. It is decreased in the acquired type systemic lupus due to kidney involvement, due to other causes, but it's not for hereditary angioedema. And it's normal in the other types. So as you can see, in type 3 factor 12 mutation and in drug-induced angioedema and in chronic spontaneous urticaria, you will find all these normal. So how are you going to does it? In the factor 12 mutation, you need to do typing. But in captopril or AC inhibitor angioedema, history is the main for diagnosis. And again, in angioedema, idiopathic angioedema, which occurs with an autoimmune phenomena in chronic spontaneous urticaria, history is the main tool for diagnosis. Let's go for this diagram. It will make things, I think, easier. We have two types of non-histaminergic angioedema or non-allergic angioedema, C1 inhibitor defects and normal C1 inhibitor. In the C1 inhibitor defects, you have type 1, type 2, and the acquired form, which occurs mainly in systemic lupus erythematosus, but in many other diseases, many other illnesses. So in type 1, low C1 level, low C1 function, C1 inhibitor function, and low C4. Type normal C1 inhibitor level, low function, and low C4. In the acquired type, here you are going to find anti-C1 inhibitor antibodies, low C1q level, and again, low C4. Cases with normal C1 inhibitor, I mean the factor 12 mutation, you will find a normal C1 inhibitor profile, and you need the genotyping. And cases with angiotensin converting enzyme inhibitors, drug-induced angiotensives, you will find normal profile. If you go, it is that simple. This will summarize everything for you. Consider the clinical features first. You have a child with angioedema without wheals, without area, or a case of laryngeal edema that comes to the ENT physician unexplained, or recurrent episodes of abdominal pain that are considered surgical abdomen, and they usually go to pediatric surgery and to the ER, or family history. Then first thing you're going to do is serum C4, which is very cheap. And if you can do the quantitative or qualitative C1 inhibitor, if possible. If you C4 level low and the quantitative C1 inhibitor low, then you are dealing with hereditary angioedema type 1. If you find low C4 and normal all or elevated quantitative C1 inhibitor, then you are dealing with, then you should do the quantitative C1 inhibitor. If it is reduced, you are to hereditary angioedema. Or if the qualitative C1 inhibitor is normal, despite you have low C4 and normal quantitative C1 inhibitor, then search for other causes of C4 consumption. If you have both normal C4, normal C1 profile, and you have a pictures very much suggestive of hereditary angioedema, then consider type 3, which is factor 12 mutation that needs genotyping. Let's go to the treatment of hereditary angioedema. We have long-term prophylaxis, short-term prophylaxis, which we call pre-procedure, before you do a surgical procedure, for instance, and treatment of the acute attacks, which is called on-demand therapy. Concerning the long-term prophylaxis pediatrics is indicated in severely affected children. Define frequent attacks of throat edema, frequent attacks of colicky abdominal pain causing distress and disability, and of course, poor quality of life, the presence of comorbid conditions such as heart disease, for instance, and the access to emergent treatment should be considered in the decision-making of giving long-term prophylaxis, because it's not easy to keep the child on treatment like this. We have main tools. The most physiologic is plasma-derived inhibitor. You have deficiency of C1 inhibitor, so you may give this inhibitor to the patient to decrease the attacks. Lanadelumab, which is a monoclonal antibody against plasma kallikrein. Plasma kallikrein, as you have heard from Dalia, is the enzyme that causes kininogens to lead to kallikrein formation. Impeded androgens, and this is the most famous, the danazole and the oxandrolone, and we use them still up till now, although they are considered now a second-line prophylactic treatment, not a line, and the fibrinolysis inhibitors, which includes tranexamic acid that you call cyclocaprone. It is used to stop bleeding, such as menstrual bleeding, but it has a function through inhibiting factor 12. Danazole is effective indeed, increasing C1 inhibitor expression. It increases, it stimulates the formation of C1 inhibitor, but it has many adverse effects, especially in children, in the form of weight gain, virilization, delayed menarche, headache, depression, and so on, even liver adenomas. However, many patients accept the adverse effects to avoid the distressing, sometimes life-threatening attacks, especially when other options are not available for them. Concerning the C1 inhibitor in the prophylaxis of children with hereditary angioedema, is a study published in 2019. As you can see at the baseline, it's a clinical trial. It's a randomized clinical trial. At baseline, 75% of attacks were moderate and 20% of attacks were severe. But after initiating this treatment, at least 50% of the children had no symptoms or mild symptoms. So it deserves, in severe cases, to improve quality of life. Lanadelumab, which is the first human monoclonal antibody against plasma kallikrein, is approved only starting from the age of 12 years. It is used in prophylaxis. It decreases the attack, but it is not intended for treatment of acute attacks. You cannot give it during the acute. It will not save the lives. It is prophylactic treatment. It is administered subcutaneously every 2 to 4 weeks. The most common adverse events are tolerable in the form of injection site reactions and dizziness. And here is the study, the HELP study. It was called the HELP study. According to this study, the drug was approved for in the prophylaxis of hereditary angioedema. As you can see, the angioedema attack rates decreased after the drug. The attack rates went down 1 attack every 2 months in comparison to the placebo group, where it was once per month. So it decreased by 75%, the attack rates. And also the attack severity, as you can see, cases tend to be mild cases or none at all, the light, no attacks, although in the placebo group, it was moderate or severe attacks. Let's go to the short-term prophylaxis, which we call pre-procedure. It is required from 1 to 12 hours before surgery, dental procedures, and after trauma. Before the child who has hereditary angioedema goes to the dentist, he should begin prophylactic treatment, because usually the stress that develops in the dentist office or the manipulations themselves can lead to the precipitation of the attack. We have 3 options according to Paula Bassi and her colleagues published in 2021, this month in January. C1 inhibitor concentrate, single dose, and it is available start at the age of 2 years. Frozen plasma, infusion of 2 units of fresh frozen to replace the missing C1 inhibitor. And the third option here is to give a high dose of danazole, 400 to 600 milligrams per day, 5 to 7 days before the procedure, and continue after the procedure to prevent appearance of the attack. And then we should go to the treatment of the acute attacks, which we call the on-demand. On-demand, we have 4 options. First, you give a single dose of C1 inhibitor, human plasma-derived C1 inhibitor, or give the recombinant C1 inhibitor, and you will see that it is not approved before the age of 12 years because it leads to anaphylaxis in some patients. The kallikrein inhibitor, which we call ecallantide, and the bradykinin receptor antagonist, which we call, which is named icatibant, are the scientific, not the trade names. And if you don't have all these in your country, then you may have to give fresh frozen plasma, 2 units, when none of the above is. It was in 2009 when Timothy Craig and his team from Pennsylvania State University proved the efficacy of human C1 esterase inhibitor comparable in abortive acute hereditary angioedema attacks in a dose of 20 units per kilogram. And then the drug was approved by the FDA based on this study. And then 1 year, there was a study by Bruce Zurau and his team that proved that timing from the first dose, when did the patient improved, okay, within time after using the filtered C1 inhibitor concentrate, the percentage of patients who improved increased with time when they gave the dose. Targeting kinin cascade, we have kininogen that turns into bradykinin by the enzyme plasma kallikrein, and then the bradykinin works on the bradykinin 2 receptor on the surface of the endothelial cells, leading to conservation of fluid and angioedema. So here you can stop. You can stop this step by giving a kallikrein inhibitor. So you prevent the formation of bradykinin. Or you can give a bradykinin antagonist, receptor antagonist, to prevent bradykinin from working on the receptor and leading to the angioedema. And this study proved the effect and safety icatibant, which is the bradykinin antagonist in pediatric patients. And based on this study, it was that was published in JACI in Practice, the drug was approved by the EMA for use in children. As you can see, the orange line is for children and the green one is for adolescents. Timing from the icatibant administration at 0. Look at this. The symptom score was very high. It decreased gradually. At 6 hours from the dose, it disappeared. All the symptoms disappeared within 6 hours of a single dose of icatibant. What about the fresh frozen plasma? This article is recently published in the World Allergy Organization Journal, and it proved that when it is the only available drug in some countries, including South Africa, Iran, and Egypt, of course, it works. Fresh frozen plasma remains the only available on-demand treatment for acute hereditary angioedema. I'm so happy that the other options will be available soon in Egypt, and this makes me very proud. Fresh frozen plasma is effective, but the problem is time to resolution. It is very slow. We all see in the ER when we have a case of hereditary angioedema and we give 2 units of fresh plasma, it takes at least 12 to 24 hours to get any response. And the problem, really, because you are so worried that the laryngeal edema will start at any time, or this patient's sinus obstruction, and you are going to have grave morbidity. The time to resolution is a very important factor in this case. Let's summarize the treatments of hereditary angioedema. First, we have the impeded androgens, and oxandrolone. Usually the effective dose is 200 milligrams per day. When goes well and improved, we can make it every other day. The advantage is that it's given oral only for prophylaxis. It does work in the acute attacks. It takes time to work, but we have a lot of adverse effects up to hepatocellular adenoma in some patients. So that's why it is not given an FDA approval in children, except in countries where nothing is available. Tranexamic acid, which is used also for prophylaxis, trade name is cyclocaprone. We all know it. It is used in a lot in gynecology and obstetrics to stop bleeding with active factor 12. The advantage is that it's given oral and can be given IV sometimes, but there are a lot of side effects, adverse events in children, including muscle cramps and increased muscle enzymes such as CPK. So these are for access only. And then we have the rest of the plasma-derived C1 inhibitor. This is used in acute attacks and prophylaxis, whether short-term prophylaxis, pre-procedure, or long-term prophylaxis. The disadvantage is that it's given IV, and the adverse events, very rare anaphylaxis, and theoretically transmission of infectious agents, although this is not proven. The recombinant is only for acute attacks. It's given intravenously, and the anaphylaxis here is not very rare. It is uncommon, but they say that it is more in patients who have allergy to rabbits, because the drug is produced in the rabbit and it is taken from the milk of the rabbit. Ecallantide or the anti-kallikrein is given in acute cases only, subcutaneously. The adverse include anaphylactoid reactions and development of drug antibodies, so by time it can be ineffective. Icatibant, which is the receptor antagonist, is given only in acute cases, acute attacks, not for prophylaxis. The advantage is that it is subcutaneous. Subcutaneous drugs are preferred than intravenous drugs where the patient has to go to a hospital to take it. But some very minor, there are common adverse events of local swelling, pain, pruritus at injection site. And the dose differs according to age. So in the pediatric age groups, dose is either 10 milligram or 15 milligram. And then lanadelumab, which is the monoclonal antibody here, it's given only for prophylaxis. It doesn't work for acute cases. It's given subcutaneous, and the adverse effects are not. The plasma one inhibitor will be licensed in Egypt soon. So we have to have a more closer look. We have two types. The one is going to be present in Egypt is the Synrise, 5 units per vial. In teenagers, more than 12 years of age, you give 1,000 units every 3 to 4 days intravenous. And of course, this is going to make some difficulty to give the patient intravenous. But you need it if the rates is high and can lead to death. And sometimes even the on-demand therapy, you may not save your patient. In children from 6 to 11 years, it is given in the form of 500 units every 3 to 4 days. Infusion rate again, 1 milliliter per minute. But if the child is obese, you can go up to 1,000 units. The Berinert, which is not available in our country, is licensed in all pediatric ages. The dose is per kilogram IV, again, every 3 to 4 days, and the infusion rate should be than 4 milliliter per minute. What about the approval? The FDA and EMA, these are the main ages that we depend on their decision, in our decisions to give a medication. The EMA is the European Medical Agency, and it's the equivalent of the FDA in USA. The plasma-derived inhibitor, which will be available in Egypt, long-term prophylaxis FDA said more than 6 years, and the EMA as well. For acute attacks, down to 2 years of age in Europe and 6 years in the US. The Berinert, any age for acute attacks, but more than 6 years, again, for long-term prophylaxis. The recombinant type, more than 12 years for the acute US and 2 years in Europe, but it's not available here. The icatibant, or the bradykinin receptor antagonist, which is called Firazyr, is given only for acute attacks. In the US, the approval is 18 years, and in Europe, down to 2 years of age. The ecallantide or kallikrein inhibitor is called Kalbitor. It is not approved in Europe, and in US, more than 12 years. It's given only in acute attack. The lanadelumab, which is called Taxol, it's given only in prophylaxis. It is not approved before the age of 12 years, whether in the US or in Europe. What is new treatment of hereditary angioedema is very interesting to me. Why? Because we have 3 options. The first option is giving the plasma-derived C1 inhibitor instead of intravenous, giving it subcutaneous. And the studies now are in phase 3, and they are very promising that this will improve the quality of life of patients. Instead of bringing the patient twice a week to give him an intravenous drug, you can give it subcutaneous in the dose of 460 international units per kilogram. The other option is that they are now in phase 3 trials for a kallikrein inhibitor oral, because the kallikrein inhibitor led to anaphylaxis in many patients. So that's why they were worried and said, we may give it oral, it will be more convenient to the patient. Unfortunately, the abdominal attacks up now did not improve a lot. The peripheral attacks improved better. And the third option is that they are trying the leronlimab, or the monoclonal antibody, which is given every 2 to 4 weeks, not twice weekly. This is more convenient to the patients, and it's a subcutaneous drug. But it is still in stage 1B, the trials, and it is really promising. The subcutaneous C1 inhibitor was tried in a multi-center randomized double-blind placebo-controlled crossover study, and it showed that at least the mild and severe attacks decreased a lot after giving the subcutaneous in comparison to the placebo in the dose of 40 or even 60. Both gave good results, and this will be more convenient to the patients. And even the attacks improved in patients below the age of 17. More than the adults, it gave a good result by subcutaneous route in the pediatric patients, and this gives us a hope from this follow-up study that remained for 2.5 years. Oral plasma kallikrein is also another hope for the patients. Most patients said if we have an oral option for long-term prophylaxis or for attacks, will be more than injectable forms. This is the trial on the lanadelumab identified on the clinicaltrials.gov of the National Library of Medicine, a phase 3 open label multi-center study, and it tries the lanadelumab in a younger age, between 2 and 12 years of age, with hereditary angioedema, because it's not licensed except from 12 years on. So this is a hope for younger children. The last slide I tell you, is there a relation between hereditary angioedema and COVID-19, which is our problem in the pandemic era? Yes, there seems to be a problem. You know that most patients with COVID-19 have a problem of hypercoagulability and fibrinolysis system. They develop a lot of thrombi. So patients of hereditary angioedema also a problem with the fibrinolysis system. So those patients, if they develop COVID-19, they are at a great risk of high morbidity from the disease. And in those patients in particular, long-term prophylaxis considered. So if you have a patient with hereditary angioedema, nowadays in the COVID-19 era, we should think of long-term prophylaxis and good control and have the on-demand therapy in hand ready to save their lives if they get the 19. My thoughts are hereditary angioedema can impact aspects of life beyond physical health, such as education and work productivity. It is also sometimes life-threatening. Early diagnosis is the cornerstone of successful management. If you don't know that this patient has hereditary angioedema, you will keep giving him antihistamines, corticosteroids, and even epinephrine till he dies. You have to diagnose it as hereditary angioedema to save the life of him. Adequate treatment requires lifelong follow-up because it is a chronic disease that will not go, and you have to follow up your patients for life. Thank you. I would like to acknowledge the pediatric allergy and immunology team of our lovely unit that was founded by our great professor, Professor Yahya Gamal, and is headed now by my dear colleague, Professor Shireen Rida. And most of my colleagues' names are here, slide and the photo. And of course, the pediatric allergy immunology integrated large team who help us very much. Thank you very much for listening.
Thank you so much, Professor Hossny, as usual. Excellent, very simplified and up to the point. Thank you so much, Professor.